Hello, I'm Dr. Sean Malarvey, and I thought I would record this presentation that I made for our local YMCA, and I'll be giving this on the 20th of April, which means that most likely I've already given it. In a way of introduction, I did graduate from the University of North Dakota with a summa cum laude distinction in the 1980s. And then in 1989, I graduated from that same institution with a degree in medicine. I attended the University of Nebraska for a 5-year general surgery residency, and I am currently a faculty of the American College of Surgeons. So, my talk today is understanding gastroesophageal reflux disease, or as it's commonly referred to, GERD, G-E-R-D. So these are the broad topics we're going to address as far as treatment options, and those include lifestyle changes, and then medical and surgical therapy. And most of the focus is going to be on what is appropriate for me. So typical symptoms of reflux disease that most people are familiar with include the chest pain, burning discomfort, or what's referred to as heartburn. Some people can have excessive salivation, a common symptom that sometimes isn't impacted by medication so well is gross regurgitation. This is oftentimes worse at night when the patient lays down. Gas, bloating, burping, these are typical symptoms. Less typical symptoms are things such as a change in the quality of the voice, hoarseness, exacerbation of asthma, continuous throat clearing, a cough, dental issues. And reflux disease is when acid refluxes up into the bottom part of the esophagus. Most of the time, the problem is the acid content of the stomach, but there are other substances in the gastric refluxate that can cause problems, so it's not necessarily acid all the time. But reflux disease is where there is abnormal or frequent chronic reflux. It is normal to reflux whenever we eat, but this is something that the esophagus can quickly clear and take care of. The basic anatomy of the gastroesophageal function is displayed in this image. The most important thing to note here is that the bottom part of the esophagus, where it connects to the stomach, is below the diaphragm. It's actually inside the abdomen. And also, the angle of His is intact. This is the angle between the top part of the stomach and the bottom part of the esophagus. Now, this picture is a two-dimensional view, but understand that this angle of His surrounds the esophagus for about 270 degrees. This is a three-dimensional valve. This is just a brief illustration of a normal valve with an intact angle of His. We swallow a bolus of food, there really is no significant reflux. Now, in a dysfunctional valve where there is no angle of His, oftentimes, this is where reflux occurs up into the bottom part of the esophagus. This is a picture of a hiatal hernia. More than 60% of patients who are over 50 who have reflux have a hiatal hernia. So just think about that. About half of you folks with reflux disease probably have a hiatal hernia. Now, most of the time it's fairly small, as is reflected in this image, and this is the most common type of hiatal hernia. It's called a type 1 sliding hiatal hernia. And what happens here is the hole in the diaphragm is a little bit enlarged, and this allows the top part of the stomach to slip up inside of the chest. And so you have a loss of the normal flap valve, because the bottom part of the esophagus is actually in the chest. And when you're inside the chest, remember, we breathe with a negative pressure. The diaphragm depresses, increases the volume inside the chest, and that actually sucks air into the lungs. Well, if it's a negative pressure system and it's sucking air into the lungs, it can also augment or suck acid reflux up into the esophagus, because the esophagus is inside of that negative pressure environment. The clinical progression of reflux disease is normal physiologic reflux, as I mentioned earlier. We swallow food, the esophagus flap valve opens, there's a little bit of reflux, and then it's rapidly cleared. And then we have symptomatic reflux disease, which are the symptoms that we earlier discussed. And if that's allowed to go on without treatment, this can develop into esophagitis, which is irritation and tissue injury of the bottom part of the esophagus. And if this progresses and is allowed to continue without effective treatment, this can develop into the complications of more advanced esophagitis. These would be things like ulcers, stricture formation, bleeding, the development of Barrett's esophagus, which can be a precursor or a risk factor for esophageal cancer, and then, of course, esophageal cancer itself. So, treatment options. Let's talk about lifestyle changes first. Obviously, we can modify our diet. We can avoid those foods and substances that make reflux worse, and the guilty parties are typically high fat foods, nicotine, caffeine, alcohol. These all tend to relax the lower esophageal sphincter. So we can stop smoking, we can lose weight, we can wear looser fitting clothing, we can adjust our sleep position by elevating the head of the bed. We can avoid eating a couple of hours before we go to bed. These sorts of things are lifestyle changes and dietary modifications. Medical treatment of reflux disease involves the use of antacids, H2 blockers, and then proton pump inhibitors. And these are ranked in their order of efficacy and onset. Antacids have an immediate effect, so they're good for if you have a piece of pizza or a glass of wine and you have some reflux, then you take a Tums or a Rolaids, and you should experience immediate relief. H2 blockers have a longer duration of action, meaning that they'll last for several hours, but it takes 10 or 15 minutes for them to exert their onset. So fairly immediate relief, but not like antacids, but they last a lot longer. And then proton pump inhibitors, these are more of a maintenance medication. They do not provide immediate relief. In fact, it takes about 4 or 5 days for the full effect of the PPIs to manifest itself. So these are maintenance medications. And medical treatment is sufficient for most patients. However, in the past few years, there have been reports in the literature of the side effects and complications of proton pump inhibitors, which are really the best acid reducing agent on the market, and they've been around since the late 1980s. There have been patients that have been on these medications for greater than 20 years. Well, sometimes it takes 10 or 20 years for side effects to become apparent and to be represented in the data. And that's what seems to be happening with the PPIs in these referenced areas. Dementia is a very weak association, but this was a recent suggestion in a retrospective study that looked at Alzheimer's patients, and it had a hypothesis. Now, this is a weak association. I do not feel that there's a significant documented proven risk of dementia in patients who use PPIs, but there is that suggestion, at least, of an association. Now, C. difficilitis is well documented as a potential side effect of the destruction of the acidic environment in the stomach, which has a purpose. That purpose is to kill bacteria. There is a documented impaired heavy metal absorption, magnesium, calcium, iron, and there is a documented increased risk of bone fracture in patients who are already at risk. These are patients who already may be suffering from osteopenia or have diabetes or other risk factors. Most significant, in my estimation, and most recently, just this past Thursday, was the last or most recent study from the Journal of the Association of Nephrology, or the Journal of the American Society of Nephrology, and that demonstrated a 96% increase in kidney failure in those patients who are taking PPIs when compared to those taking H2 blockers. Now, it's still a small percentage, 2% to 4%, but this seems significant. And there is a 28% increased risk of chronic kidney disease. Now, this follows an earlier study in January of this year in JAMA, Journal of the American Medical Association, and this demonstrated an increased risk of chronic kidney disease of 14.2 in those taking PPIs versus 10.7 per 1,000. So now both of these studies are retrospective. They don't prove a causal relationship, but it does suggest an association. So what are some options for anti-reflux surgery? Well, the standard laparoscopic Nissen fundoplication has been in practice for 15 to 20 years, and prior to that, the Nissen fundoplication had been in existence for close to 50 years. And laparoscopic surgery is performed through 3 to 5 small incisions. It allows the repair of a hiatal hernia and a reconstruction of the gastroesophageal valve. There is a procedure called the TIF, which is a transoral incisionless fundoplication, in which the fundoplication or gastroesophageal valve is built using a device that has advanced down the esophagus. And then most recently, there's this metallic ring of magnetic beads called the LINX device, a LINX procedure, and this does require laparoscopic surgery for placement. So these are images of a Nissen fundoplication. You can see that this is a 360-degree wrap. So the esophagus is wrapped around the stomach is wrapped around the esophagus 360 degrees. This has been successful. It's durable, reasonably so. After about 10 years, maybe half the patients are back on medications because the wrap can be defeated with the stress of life, weight gain, overeating, those sorts of things. There is an adverse event of about 25%, most commonly dysphagia or trouble swallowing. The wrap is 360 degrees, so that's better than normal. Normal is 270 degrees. Some patients have trouble burping or throwing up because of the existence of the wrap. Now, these alternative solutions or less invasive solutions of the TIF and the LINX can largely replace the Nissen fundoplication potentially. So let's first look at the TIF. This is a schematic of the suture material that's placed utilizing the device, and this recreates the angle of His, 270 degrees around the bottom part of the esophagus. So this does replicate the ideal normal situation. The benefits of the TIF are that it is truly incisionless, so there are no scars. There's no internal dissection. There's a fairly quick recovery because of that. This can be done as an overnight stay, sometimes as an outpatient. Because it is a partial wrap, there is a low incidence of dysphagia. It can be redone in the future if necessary, and it doesn't limit the future treatment options. 80% of patients are off of PPIs at 24 months. 90% of the patients are satisfied or at least neutral with the procedure. And 80% have noted an improvement in their quality of life. And most importantly, there is a reduced dependency on daily PPIs. Now, this is a picture of an actual patient with a small hiatal hernia that you see on the left. On the right, the image is that of the hiatal hernia that has been repaired. And then, following the repair of the hiatal hernia, this is a TIF procedure that was completed. And you can see that it recreates the angle of His about 270 degrees, not quite all the way around the bottom part of the esophagus. And this patient went from a reflux scoring system of 34, which is bad, pre-op, to a number 4 post-op, which is good. Now, a LINX procedure requires laparoscopic surgery because this metallic bracelet has to be placed around the bottom part of the esophagus. So this is not done through the mouth, this is done laparoscopically. Clinical research suggests that it has results that are at least as good as the TIF patients that we talked about a few slides ago. 80% are off of PPIs at 2 years. 90% have noted a significant improvement in the quality of life. And this device is very durable over time because it's metallic, it's mechanical, it's not subject to breakdown like a surgical repair might be over time. It can be removed, and in fact it is removed in up to 6% of patients because of complications or difficulty swallowing. So let's look at a comparison of the two briefly. Transoral fundoplication uses Prolene suture, and the laparoscopic LINX uses this metallic bracelet. Because it's metal, you have to be very careful with MRIs, and the device has to be rated, or I would say the MRI has to be rated specific to the device. So if you do have a LINX device, you need to know which MRI machine it is allowed inside of. Now, with a TIF procedure, you can do this following a hiatal hernia repair, which does require laparoscopic surgery, but a hiatal hernia is a contraindication to the LINX device, because if you have a hiatal hernia, the LINX device would end up inside of the chest. Postoperative dysphagia at 1 week in the TIF patient is 4%. Postoperative dysphagia with the LINX device is quite common at 1 week, but it rapidly improves over time. At 1 year, it's still 11%. At 3 years, it's 4%. So, after all that, what is right for you? Well, that's a multifactorial question. There are these things called comorbidities. This is like obesity, COPD, diabetes. Then there's the medications. How many medications do you require? Do you require once daily dosing of a PPI, or are you taking it twice a day, or can you get by just taking H2 blockers? How old are you? Are you 50 years old? Are you 50 years old? Are you 99? And then your symptoms. How severe are your symptoms? How impaired is the quality of your life because of your reflux disease? See, it's not really a white and black, cut and dried. It's a combination of things, and this is something that you need to make a decision on after a careful discussion and consideration with your doctor. The goal is to control reflux disease medically with the least amount of medication possible. And so we start at least H2 blockers like Zantac and Pepcid, antacids. A little bit more would be once daily dosing of PPIs like Prilosec or Nexium or Prevacid. A little more than that would be once daily dosing of a PPI with the supplemental use of H2 blockers or antacids. And then the most would be BID dosing, twice daily dosing of a PPI, and the potential use of H2 blockers and antacids. And I do have patients that, it's not that uncommon to have patients who are on the most amount of medication to control their symptoms. So what are the indications for surgery? Well, we talked about this multifactorial comorbidities, medications, and age. So if you have patients who are PPI dependent, you depend on the PPIs, and if you're younger rather than older, and if you're in a good baseline level of health, then it would be reasonable to consider surgical intervention. If your symptoms are not responsive to medications, like you have gross regurgitation, or you have atypical symptoms of reflux disease, what's called laryngopharyngeal reflux, like a sore throat, a chronic cough, dental issues. These are symptoms that might not be related so much to the acid, but rather to the other components of the refluxate. As long as you have documented proof that you do have reflux disease and your symptoms are not responsive to medication, then it would certainly be reasonable to consider surgical intervention. So if surgery, what surgery? Well, if you have a hiatal hernia, that kind of precludes a LINX procedure because that is a contraindication to the LINX device at this point in time. I think that in the future there will be some discussion about doing a hiatal hernia repair and then placing a LINX device, but that really hasn't trickled into the literature yet. In patients that do not have a hiatal hernia repair, there is the option for either the TIF procedure or the LINX device. Now with the TIF procedure, and if there's no hiatal hernia, that can all be done transorally without abdominal surgery. And as I've illustrated earlier, the LINX device does require laparoscopic placement. The one thing I didn't really mention up here on the top is a hiatal hernia. With the presence of a hiatal hernia, you can repair that laparoscopically and then follow that immediately with the TIF procedure. This is still less invasive than the gold standard, which is classically described as a hiatal hernia repair and a Nissen fundoplication, which is more invasive because that does require a complete separation of the stomach from the spleen and a more comprehensive dissection around the top of the stomach than is required with a simple hiatal hernia repair, which is then followed by the transoral fundoplication. Well, this concludes my talk. Thank you so much for your attention. You may contact me through the following link. I don't contribute to this blog very often, but this would be a mechanism for contact information. Thank you.